Hi, it's Tammy Valenta, and we're going to talk about cardiovascular heart sounds and murmurs.
Boom, 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 boom. Oh, that was scary, wasn't it?
The first heart sound, S1, is synchronous with the pulse in your carotid artery in your neck. It marks the beginning of systole with the closing of the mitral and tricuspid valves and is heard loudest at the apex. If the valves are wide open during ventricular contraction, S1 will be loud. This can occur with anemia, fever, or hyperthyroid. Mitral valve stenosis will also cause a louder S1. If the valves are partly closed during ventricular contraction, S1 is faint. Beta blockers produce a fainter S1, as do structural changes in the heart valves such as fibrosis and calcification of the mitral valve. Non-heart related factors such as obesity, muscularity, emphysema, and fluid around the heart can reduce both S1 and S2. The second heart sound marks the beginning of diastole and is best heard at the base. It may be more pronounced in children and teenagers. Right ventricular ejection time is slightly longer than left ventricular ejection time. As a result, the pulmonic valve closes a little later than the aortic valve. The split S2 is a common event heard over the pulmonic area at the end of inspiration. The sound is heard when the aortic valve closes significantly earlier than the pulmonic valve, and both closures are heard separately. Normal or physiologic splitting of the second heart sound is associated with inspiration because the closure of the pulmonic valve is delayed due to the increased blood return to the right side of the heart. An S2 that remains split during both inspiration and expiration is referred to as a fixed split S2. Causes of a fixed split are bundle branch block, left or right, chronic high blood pressure, pulmonary hypertension, or it may occur during exercise or excitement. Diastole is normally silent. An S3 sound, also known as a ventricular gallop, is caused by vibration of the ventricular walls. It is heard at the apex after S2 and sounds like Kentucky, with the last two syllables coming in rapid succession. Once the ventricle reaches maximum filling and the ventricular walls are distended, the kinetic energy of the blood's movement is converted to vibration. These vibrations can sometimes be heard. The S3 sound is common in normal, healthy children and in young adults under the age of 30. It is found in 80% of pregnant women during the last trimester. An S3 heard over 40 years of age usually indicates pathology. The most useful importance of S3 is in in detecting left-sided heart failure, especially in the early stages when other signs may be normal. In a study of patients awaiting heart transplant, an S3 was one of 7 risk factors predicting a poor prognosis. Mitral valve regurgitation can cause S3 without heart failure. It is also common to hear an S3 after an acute heart attack. This usually disappears several days or weeks afterward. Persistent S3 after this time may mean more severe heart damage.
To improve your ability to hear S3, S4, and the murmur of mitral stenosis, have the patient roll partway onto his left side, which brings the left ventricle closer to the chest wall. Then recheck the position of the apical impulse and place the bell lightly on it. If the patient had an audible S3, it would sound like this. Now, notice how the third heart sound disappears when the bell is placed more firmly on the chest wall. Listen again with light pressure. With firm pressure. And once again with light pressure.
Now I'd like for you to lean forward, take a deep breath in, breathe out completely, and hold it.
To help detect aortic murmurs, especially that of aortic regurgitation, have the patient sit up and lean forward. Then ask him to exhale completely and hold his breath out. Using the diaphragm of the stethoscope, listen at the left second interspace and down the left sternal border to the apex.
Breathe out completely again and hold it.
Pause periodically to allow the patient to breathe. Listen for the high-pitched diastolic murmur of aortic regurgitation. If the patient had this murmur, it would sound like this.
You may breathe. Take another deep breath. Breathe out and hold it.
Heart murmurs can be distinguished from heart sounds by their longer duration. Diastolic murmurs, like this one, usually indicate heart disease. Systolic murmurs can occur in healthy people or in those with heart disease. For example, a loud mid-systolic murmur may be heard in aortic stenosis. If you hear such a loud murmur, palpate the area with the ball of your hand. Palpable vibrations associated with a heart murmur are called a thrill.
An S4 sound, also known as an atrial gallop, is a low-pitched, dull sound that occurs in late diastole, just before S1, and is heard at the apex. The sound is similar to Tennessee. As with the S3 sound, S4 is thought to be caused by the vibration of valves, supporting structures, and the ventricular walls as the atria push blood into a non-compliant ventricle. An S4 can be heard in any condition that is associated with left ventricular hypertrophy. It seldom occurs in normal hearts, except in well-trained athletes as a result of hypertrophy of the left ventricle. It may be heard in pregnancy due to augmented ventricular filling. Heart sound components S3 and S4 fuse during fast heart rates, creating a short, low-pitched, mid-diastolic sound between S2 and S1, known as a summation gallop. It is an intense, easily heard sound that resembles the sound of a galloping horse that is best heard at the apex. It is while the patient is supine or in a left lateral position. The sound may be louder than either S1 or S2 and may cause a visible apical lift during diastole. The occurrence of a summation gallop increases with inspiration, exercise, elevation of the legs, and with increased venous return. When the heart slows, the summation gallop is replaced by separate atrial and ventricular gallops, producing a quadruple rhythm much like the canter of a horse. It usually results from heart failure or dilated congestive cardiomyopathy. Murmurs are caused by turbulent blood flow. They are generally considered abnormal and are considered pathologic until proven otherwise. Valvular disease and structural defects create murmurs, as do increased velocity, as in exercise, decreased viscosity, as with anemia, and other structural defects. Aortic stenosis, aortic regurgitation, mitral valve regurgitation, and mitral valve prolapse are common valvular diseases.